So thanks for everyone for coming out. So you're at the Trainee Research Presentation for the Women's Health Cluster. And we've got 4 incredible speakers today. So Emma unfortunately couldn't make it, so I'm sure she'll be doing the September Trainee Research Presentation. I will definitely encourage people to be tweeting throughout it if you hear something really interesting or have questions, and you can use the hashtag Trainee Blitz up on the screen. And before we begin today, I'll just share a land acknowledgement. So we recognize that we live, work, play, and participate in community on the unceded, ceded, and traditional territories of the 203 First Nations, along with 38 Métis charter communities, each of which possess their own unique traditions and history here on this land that we now refer to as British Columbia. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's Call to Action, the United Nations Declaration on the Rights of Indigenous Peoples, and the BC Declaration on the Rights of Indigenous Peoples Act. In all our work, we are committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, this isn't quite right. I'm not joining you from Vancouver, but that is where I live, work, and play, which is part of the unceded homelands of the Coast Salish and traditional territories of the Musqueam and Squamish and Tsleil-Waututh First Nations. And I'll just invite everyone joining in today to take a moment to acknowledge and have a moment of gratitude for the lands that you are joining from today. A little bit of info about the cluster. Many of you may be cluster members, and if not, I would encourage you to become a member, and there's the email down at the bottom right of your screen. Just send an email, and being part of the cluster is totally free, and it gives you access to lots of interesting events and education. So we have over 375 members, and that includes UBC faculty, affiliated members, community partners, and many, many trainees, a few of which are going to be hearing from today. We put on many different types of events. So today is the Trainee Research Presentation Series, which happens quarterly. We also have a Women's Health Seminar Series, the Tri-Cluster Research Day, put on numerous community events, several different conferences, and each of these events is really informative and just brings together such a great group of people. Our members work in diverse fields of research, and that includes medicine, economics, social sciences, humanities, nursing, anthropology, gender studies, land, food systems, psychology, education, and I don't even think that quite covers it. We're very lucky to have a very diverse group of researchers. I would also encourage you to check out the Women's Health Interrupted podcast. They've put out some awesome podcasts on a variety of topics, and the Women's Health blog, which also includes work from both trainees as well as faculty on a variety of different women's health topics. And recently, we also gave out some trainee travel awards, which allow us to support trainees going to conferences and workshops. And we couldn't do this without our collaborations and support. So probably won't list them all, but BC Support Unit, the Women's Brain Health Initiative. We have many individual donors, as well as the largest support from UBC and CIHR and Biotalent. And if you are interested, we also do accept donations to do this important work. And so you can also email that same email address that's down on the screen there. So I think without further ado, I'll stop sharing my screen and I will just introduce, I guess we didn't actually go over order, but maybe I'll just go with the order that's on the screen for the trainee research page. So if it's okay, I'll start with Amanda. So Amanda is a second-year Master of Science student in the Population and Public Health, who is co-supervised by Dr. Jillian Hanley and Dr. Tim Overlander. Her thesis uses a population-based approach to investigate the association between antibiotic exposure prenatally during labor and delivery with the risk of autism spectrum disorder in offspring. So enough from me. I will hand it over to Amanda. So Amanda, you can start sharing your screen if you're able to.
Okay, thank you. Can you see the screen properly?
Looks great.
Okay.
And yeah, just I won't flag you at 5 minutes, but if you're going way over, I'll send you a chat, but I'm not too worried about it.
Okay, thanks. Okay, so today I will be briefly discussing a portion of my thesis research, which is looking at the association between prenatal antibiotic exposure and the risk of autism spectrum disorder. So antibiotics are among the most commonly used medications during pregnancy, and while their short-term benefits are clear, their potential long-term effects are underexplored. Antibiotic exposure induces changes in the maternal microbiome, and in turn, this can then impact the colonization of the infant's microbiome at childbirth. Also, recent research suggests that maternal microbiota may be influencing fetal development even before birth. So through the proposed mechanisms of the microbiome gut-brain axis, an altered microbiome during early life could be an important risk factor for neurodevelopmental disorders like autism spectrum disorder, or ASD. So the objective of the study was to examine the association between prenatal antibiotic exposure and ASD in offspring. We used a population-based retrospective cohort study design and included everyone who delivered a live singleton infant in BC between April 1st, 2000 and December 31st, 2014, with follow-up until December 31st, 2016. And this resulted in a sample size of just below 570,000 children. The exposure was defined as filling one or more antibiotic prescriptions during pregnancy, and this was identified through the BC PharmaNet. And the outcome of interest was a clinical diagnosis of ASD identified through the BC Autism Assessment Network. We used Cox proportional hazard regression to calculate crude and adjusted hazard ratios and their 95% confidence intervals. And we stratified our analyses by trimester of exposure, antibiotic class taken, duration of exposure, and then sex and mode of delivery in order to examine for potential effect modification. And then finally, we conducted a discordant sibling pair analysis to further control for any unmeasured genetic or environmental confounding. So overall, we found that prenatal antibiotic exposure was associated with a small statistically significant increase in risk of ASD of about 8%. And this was specifically seen for second trimester exposure. Penicillins and other beta-lactam antibiotics were associated with the highest risk of ASD of about 6 and 10%. And then when looking at cumulative duration of exposure, we observed a dose-response relationship with the highest risk associated with exposure lasting longer than 2 weeks. Upon stratifying by sex, we found the highest risk among female offspring, whereas no effect modification was observed based on mode of delivery, with vaginal and cesarean deliveries associated with roughly the same risk. And this could be suggesting that an altered microbial colonization at childbirth and its potential impact on infant neurodevelopment is not likely the biological mechanism behind the observed association. After conducting the sibling pair analysis, the association remained positive, however, it was weakened and no longer statistically significant. So this suggests that some residual confounding likely remains and that these findings should be confirmed in future studies. So in summary, prenatal antibiotic exposure was associated with a small statistically significant increase in ASD risk, specifically for second trimester exposure. The second trimester of pregnancy is a period of rapid development of the fetus and the fetal gut. So this may be a particularly sensitive time for metabolic programming by the maternal microbiome. Animal research has suggested that metabolites produced by the maternal microbiome could be affecting brain neurodevelopment of offspring. So antibiotic-induced changes to the maternal microbiota and their metabolites may underlie these trimester-specific associations with ASD risk. But that being said, future mechanistic studies are required to support that hypothesis. And then in terms of next steps, I'm currently in the process of stratifying my analysis by different indications for antibiotic use. So different locations of infections as well as infectious agents in order to properly assess the potential role of confounding by indication.
Thanks, Amanda. Super interesting work. I will leave the floor open for questions. And I believe you can just unmute yourself to ask the question, or you can also type it in the chat and I can read it out. And if not, I'll ask the question because I always have questions to start. So Amanda, thanks for presenting. That was great. And I've seen this work before too, and you kind of answered my question at the very end that I was going to ask, but I was wondering about the tie between antibiotic exposure versus the infectious agent, like which is the chicken or the egg. So is that what you're going to be looking at a little bit to try and tease that apart, whether it's actually the infection in the second trimester that's potentially increasing risk for autism or the antibiotic exposure? Is that kind of the purpose of those next analysis?
Yes, so I'm basically going to stratify by, so during pregnancy, the most common infections that are treated with antibiotics are genitourinary tract infections like UTIs or respiratory tract infections. So I'm putting together ICD-9 codes that would classify into those two categories, and I'm going to run all of the different analyses within these different restricted cohorts to try to just control for that the potential of the confounding by indication. And then I will look at bacterial versus viral infection ICD-9 codes, even though I'm not sure how many viral infections would have been treated with antibiotics, but it still happens. So I'm interested in seeing what that sample size is like.
Mm-hmm.
A lot. It's confounding by indication is a really key factor of any type of research involving medication use. So I definitely want to give it the proper attention.
Mm-hmm. Yeah, interesting. Any other questions for Amanda? Carrie, yeah, go for it.
Hi, I'm not super familiar with this area of research, but I think it's really cool. What I've heard is that girls are less likely to be diagnosed with autism until later on in life. And I think you mentioned that you had a certain area up to 2014, which would mean the girls would be about 8 now. I'm just wondering if you think, I know you said the risk observed is a little higher for girls, if you think that's still an underestimation.
With the follow-up time, when I looked at the mean follow-up time for the cohort, it was about 8.7 years. And then if I look at the average age of ASD assessment in the BC Autism Assessment Network, that's about 5.6 years. So I think we did have a solid amount of follow-up time. In terms of usually some research says that girls are less likely to be diagnosed with ASD. So from my readings, it looked like boys were about 4 times more likely than girls to be diagnosed with ASD. I feel like that's being challenged now just because children who identify as girls are usually more quiet and introverted. So those kind of signs, diagnostic signs, are missing. But in terms of why antibiotic exposure would be leading to a higher risk in females versus males, I would be really, like, I'm searching the literature right now. I can't really find any reasons. Maybe it's to do with sex hormones during brain development. But I know that a similar association has been seen for antibiotic exposure and the risk of obesity in children. So I think that's interesting.
Yeah, thank you. It's super cool research.
Any others? Remember to look at the chat. All right. If not, thanks, Amanda. That was really interesting. Okay, so maybe if you mind stopping sharing your screen. Thanks. Okay, so next up we're going to have Kara. So Kara A. Davidson, MSc, is a PhD student at Western University in Health and Rehabilitation Sciences, programs Measurement and Methods stream. She specializes in mixed methods research regarding gender-based violence, breast cancer, and women's health. Kara aims to integrate considerations of gender-based violence across the scope of women's healthcare to address health disparities. Go ahead, Kara. You're muted.
Do that every time. Just making sure. But you can see my screen okay? That's all good?
Yeah, that's great.
Okay, awesome. Thanks. Okay, so thanks for joining me here today. I'm here to discuss my research program for my PhD, which is exploring the intersections between breast cancer and intimate partner violence. So we know that 1 in 8 Canadian women is expected to be diagnosed with breast cancer in her lifetime, and that makes it the most common cancer among Canadian women, excluding non-melanoma skin cancers. It's also incredibly deadly because it's known as the second leading cause of death from cancer in Canadian women. When it comes to intimate partner violence, or IPV, this is a pervasive type of gender-based violence that about 44% of Canadian women experience in their lifetime. IPV can be understood as a pattern of physical, sexual, and/or emotional violence by an intimate partner within the context of coercive control. And you're probably wondering, especially if you come from a bio background, how important could something like violence really be in the context of something like breast cancer? And when we talk about breast cancer, the literature tends to be very bio-focused. So talking about things like genetic markers like BRCA, family history, dense breast tissue, and so on. But today I'd like you to consider whether we adequately consider life, which is, according to the Canadian Medical Association, the largest determinant of health. And you can see that life factors can account for about 50% of what makes Canadians sick, but we don't really talk about breast cancer in the context of life or social factors. And when it comes to that intersection between IPV and breast cancer, we find that about 42.5% of breast cancer patients report having experienced IPV at any time, and about 12.5% are experiencing IPV at the same time as breast cancer. And this intersection is actually quite harmful. So what we like to call in the IPV field re-traumatization, or even the perceived potential for re-traumatization, can compromise women's cancer outcomes by jeopardizing their participation in cancer treatment and follow-up care. For example, a mere 2-week delay in breast cancer surgery increases a woman's risk of death by 4%, and this risk will keep climbing with delay. So it goes up to about 26%, up to 12 weeks of delay. Women who continue breast cancer treatment despite re-traumatization can experience increased mental and physical symptoms, reduced cancer-related well-being, and reduced cancer-related functioning. And this is what we know from very limited inquiries. Accordingly, the 3 objectives of my research program are to identify the prevalence of IPV for Canadian women with breast cancer, and also look at the biopsychosocial characteristics that are associated with this intersection. I'm also developing a tailored trauma and violence-informed care tool that would empower breast cancer care providers to avoid re-traumatization and prioritize health outcomes for women who have experienced IPV. And then finally, in the third study, we'd like to test this tool to see if health disparities can be addressed for women with breast cancer and a history of violence in a safe manner. So to talk a little bit about the first study, we're in discussions with Rethink, a Canadian-based breast cancer nonprofit, to recruit our sample. They're connected to over 30,000 women in Canada, some in active treatment, others with just a history. And we're proposing a mixed methods approach. So using a survey to collect demographic data, breast cancer history, relationship history, and perspectives on care. And then following that up with semi-structured one-on-one interviews to help contextualize those findings. And essentially, we're hoping that these data will allow us to form an estimate on the prevalence of IPV for women with breast cancer in Canada, and also begin to connect IPV with breast cancer in terms of biopsychosocial characteristics like genetics, type of violence, age of onset, and so on. The second study, the Trauma and Violence-Informed Care Tool, it has strong potential to improve breast cancer care. It's been successful in things like perinatal settings, primary care settings. It just hasn't quite made it to the cancer setting. And ideally, this would provide breast cancer health professionals with an understanding of how patients are perceiving their IPV histories impacting their breast cancer care. This will involve 5 stages of mixed methods development to inform the final tool, which will then be validated in a sample of breast cancer patients who have experienced IPV, as well as breast cancer health professionals. Just an example item of the tool would be, I am hesitant about selecting treatments that remind me of previous experiences of abuse and/or violence. And that would be answered on a Likert agreement scale, and that, for example, would indicate treatment hesitancy. As for the final study here, this is a pilot and feasibility study just to test the tool's efficacy using a control hospital clinic and an intervention hospital clinic. The intervention site providers would be trained in trauma and violence-informed care, how to use the tool, as well as how to screen for IPV. The control site would just continue their normal procedures. And we would have providers conduct medical chart audits over time to report patient outcomes like treatment adherence, symptoms, and health outcomes. And patients and providers in the intervention group would then evaluate the tool's safety, appropriateness, acceptability, and efficacy, as well as their satisfaction with care. And this would ultimately uncover the impacts of the tool and whether it would help to mitigate health disparities safely. The implications of this study, I can't promise anything, but I can tell you what we hope to find. So first, to discover the first evidence of the relationship between IPV and breast cancer, biomarkers, treatment, and outcomes in Canada, and also to go further to open doors to actually improve treatment for these women by introducing and evaluating a novel trauma and violence-informed care tool. And just to give you an idea of the impact that this could have, 17 out of every 40 patients could be affected if we were to improve treatment. With that, I'd like to say thank you. You're welcome to ask questions here, of course, but if you think of something after you'd like to get in touch, my email, LinkedIn, and Twitter are on the screen. Thanks.
Thanks. Oh, maybe you want to pull up your screen one more time. I think I missed the slide with the.
No problem. Is that okay?
Not saying just yet, but oh, there we go. Yeah, so if anybody wants to get in touch with you. Really interesting work. Does anyone have any questions? And you don't even need to put your hand up, you can just unmute yourself. They're all awesome. Yeah, really, first of all, I love the use of artwork on your slides. I think that's so cool. I guess one thing I was wondering, just sort of a clarification, and you did talk about this, but essentially sort of part of this hypothesis is that women might be delaying care who potentially have experienced IPV. Is that kind of one of those key links, and that better trauma-informed care could help them not delay care? Is that sort of like maybe one of the underlying pieces of this?
Yeah, so one side of it is that women who have experienced violence or are currently experiencing violence, on the first side of things, if it's in the past, care might be re-traumatizing, and then they're more likely to avoid it. And obviously that leads to poor outcomes. For women who are currently experiencing violence, they might not be choosing to delay care, but their partner may be controlling them in a way where they can't access medical treatment. So by screening for IPV and providing care in a way that wouldn't be re-traumatizing and that would feel safe for the women, we hope that that would help prioritize their health outcomes.
Definitely. Yeah, this is not my area at all, but I did remember reading something about a story where patients were considering double mastectomy as a treatment option, and a partner basically saying no, that you're not going to do that. So I think that could be really, really interesting. This is very topical, especially for cancer research, because we haven't, like you were saying, it sounds like there's more trauma-informed care awareness in perinatal health, like obstetrics gynecology, that hasn't really made its way to the cancer world. So sounds like a lot of maybe other gynecological cancers could learn something from this too.
Absolutely. Yeah.
Any other questions, Farah? No. Oh, okay. Stunned to silence. It's really interesting work. I'll be really interested. Hopefully you'll come back and tell us once you have some findings. So
I could do that. Sure.
Yeah. Thanks, Kara.
Thank you.
Okay, so next up is Zola. So Zola was awarded the Take the Lead Scholarship, a first-year tuition and residence scholarship for international public speaking. Zola is a Queen Elizabeth II Diamond Jubilee Scholar who's collaborated with various organizations such as Education for Better Living in Tanzania, Regional HIV/AIDS Connection, Plan International Canada, and the Sexual Assault Center of London. Her passion for education and sub-Saharan Africa has led her to start OBD Ventures, a youth-led organization through the Resolution Project Fellowship. As a researcher, Zola is interested in women's health, intimate partner violence, and service utilization. Currently, Zola is a Canada Graduate Scholar and Master's student in the School of Health Sciences at Western University, with a research focus on intimate partner violence and mental health services in Ontario. Take it away, Zola.
Hi, everyone. So my name is Zola. I'm currently doing my master's at Western University under the supervision of Dr. Tara Mantler. I'm missing something. Yes, I'm in my first year of my master's. So today I'll be presenting what I have so far of my master's thesis. But yeah, so we're going to be looking at mental health services and intimate partner violence and COVID-19. Oh, suddenly I don't know how to use PowerPoint anymore. Okay, I won't go over the major sections, but these are a little bit about the sections that we'll be going over, not in detail at all. So I will be under the time limit. Just a little bit of background, and I won't have to go into it too much about what exactly intimate partner violence is, thanks to Kara, who just went over it. But intimate partner violence is a form of gender-based violence that can present itself either physically, sexually, financially, emotionally, and is perpetuated by an intimate partner. And during COVID-19, you know, I'm sure all of you know that we watched the world, you know, turn upside down. But with that, we also found increases in severity and intensity of all forms of abuse. At the same time, we also saw higher rates and sometimes lower rates of intimate partner violence service use. So as a result of the COVID-19 pandemic, governments and organizations alike, they set public health protections, which, although absolutely necessary, you know, to protect public health, it meant that many services were either functioning kind of on a hybrid type style, or just some of them were completely closed, or some of them just weren't able to kind of communicate their presence as effectively as they were doing before the pandemic. And what this meant for individuals experiencing intimate partner violence, it meant that they either didn't have any places to go as much as they did before, or just didn't know, which is kind of a recipe for disaster if you consider that the intimate partner violence occurrences were increasing. And so upon further research, I found that kind of this shuttering of services, and the shift in service care delivery accompanied by the increase in abuse really kind of shook the mental health service world. And the gap in the literature that I found is that there isn't enough evidence on the experiences of women experiencing intimate partner violence with mental health services during the pandemic. And not just kind of that concept, but looking at that concept from the perspective of women themselves. So oftentimes the literature has, lots of commentaries, which understandably so, COVID is happening super quick. But in order to truly capture kind of what is needed for effective service delivery, we need the perspective of women. And so that made a window for my thesis study, which is my purpose, that is to examine mental health service access and satisfaction during the COVID-19 pandemic amongst women who have experienced IPV/are experiencing IPV in Ontario. I'm trying to move the thing around and see at the same time. Okay. So to do this, I'm going to be conducting a quantitative cross-sectional study. Now, important to note, this isn't on the slide, but this thesis study is a part of a larger study that's going to be looking at self-compassion and resilience and mental health for women experiencing IPV during COVID-19. And so mine specifically is a quantitative cross-sectional study. So I'm going to be collecting data just at one time point. And in terms of kind of my inclusion criteria, I'm looking at women who have had IPV experiences or are currently having IPV experiences in the past 12 months, living in Ontario, so sorry to BC, over the ages of 18 years old, as well as have access to a safe computer or telephone number. My data collection will consist of a 5-part survey. So there's demographics, there's kind of that identification component, but kind of that main part that I'm going to be looking at is I have a survey on kind of the barriers to access for mental health services, as well as the satisfaction with mental health services, but also kind of a non-comprehensive list of various mental health services that women may be accessing. And also kind of on that same note, mental health services in the context of the study are very broad. So they range from pharmacotherapy to psychotherapy. They can be delivered in more acute care settings, but also in more community-based settings, such as community groups, women's shelters. But I also did include police as well. Not just because in some instances, police are in the position to respond to crises for intimate partner violence in Ontario. So currently I am just starting recruitment, and by just start, I mean I will likely be posting my first post tomorrow. I'm just starting recruitment, and then I'm going to move on to the analyses component, where I'm going to be running a 2x2 ANOVA, looking at both the access and the satisfaction. And in terms of the knowledge translation, I really hope that the knowledge generated from my thesis will be able to inform service delivery and service design for intimate partner violence as we continue to live in a world where both intimate partner violence and COVID-19 exist, unfortunately. And with that being said, thank you so much.
Great talk, really, really important work. Does anyone have questions?
I have a question, a quick question. Great presentation. I was wondering if you are going to be looking at also kind of social support and how that might be affecting these women as well. And social support in terms of thinking people in their lives outside of the help that they're getting, as well as social support within different kind of treatment options that they're applying for. I wonder if you're going to be looking closely at that.
Yeah, I'm definitely going to be looking at the support that exists within certain treatment options, just because the mental health service list is very vast. However, something that I hadn't kind of focused on that you just said was the informal support piece. And that's a piece that I hadn't intentionally considered yet. I'll definitely look into that.
Yeah, I think it'd be very interesting because there's lots of findings of effects of social support on mental health. That'd be great.
And
well, yeah,
just,
awesome work.
Just to clarify, in terms of social support, you mean kind of the informal support piece, right? That's not directly a service.
Yeah, I'm thinking informal support from friends and family, but also looking into some studies. It's also the social support in terms of things like when it comes to exercise treatments and things to help with, or other treatments to help with mental health when it comes to doing in a group versus alone. Sometimes the group, there's some great effects that come from that support. So it'd be great to look at kind of group support versus kind of single treatments as well.
Yeah, absolutely, definitely. I won't be looking at that, but it's definitely something I'm going to keep in mind.
Yeah, awesome work.
Thank you.
Great points, Travis. Anyone else?
I have a question. Sorry, I think I froze. First of all, great presentation, really interesting research. I was wondering if you have any anticipated challenges with recruitment that you're kind of like keeping in mind, or do you think it will be challenging to get enough women who want to open up or feel safe to participate in online surveys that have gone through these experiences?
That's a great question. Personally, my main challenge is probably kind of the time of the year in which recruitment is being started tends to be a little bit on the slower side. In terms of kind of the technicalities, or I guess the broader qualms with doing IPV research, this is my first time. And so Kara's also on the larger study, and I'm not sure, not to put you on the spot, Kara, but if Kara will probably have a little bit more insight to offer on that question.
Yeah, I've recruited a few times through Kijiji for this population, and it's actually been quite successful. One of our eligibility criteria is having access to a safe device, and there is research to support that. Women know best whether or not their device is safe, and we give them that agency. Like, there's no testing about that or anything like that. We haven't had any incident reports as far as I know, so it's been okay. And I think the other component of recruitment, we often go through women's shelters, and that's really helped to facilitate things because they are in a safe space. They've definitely experienced IPV, and there they would have the resources to participate virtually.
Thank you.
Thank you, Kara.
Anytime, happy to help.
That's a great insight. Yeah, I did a social media recruitment for my thesis too. So there's good parts and bad parts, but it's nice to have it as a tool. Time for one more question, maybe. Okay, I'll just ask my quick question then. Have you considered having an option for a short answer if people want to share? It would add more work, but I don't know if that's something you'd be interested in, just having it as an option for people.
I think there are maybe like 1 or 2 questions that have the option for a short answer. It has like, it'll be if not, but why. Apart from that, that's not an option anymore.
Okay, so they're like pre-made survey sort of thing. Gotcha. Curious. Awesome. Well, sounds like great work, and I would also hope that you come back and share your results once you have them, because we'd love to hear how the study goes.
Absolutely.
Sounds great. Okay, and last but certainly not least, we have Catherine. So Catherine, oh no, Corbett or Corbet?
Corbett, yeah.
Corbett, okay, is a first-year resident physician in internal medicine at the University of Calgary's Cumming School of Medicine. She's conducting research in nephrology under the supervision of Dr. Sandra Zimanski. Specifically, her research is focused on better understanding sexual dysfunction in women with chronic kidney disease to inform the effective identification and management of its symptoms. Before coming to Calgary, Catherine completed her medical school training at the University of Toronto and earned an undergraduate degree in chemical engineering from Queen's University. Go ahead, Catherine.
Perfect. Thank you so much for the introduction. I'll just share my screen here. Great. So as Alex already said, hi, I'm Catherine. I'm one of the first-year residents in internal medicine in Calgary. And this is my project that I'm just going to present the preliminary results of. That's looking at sexual dysfunction in young females with kidney failure being treated with dialysis. So just starting with some background, sexual dysfunction is very common in kidney failure. And in women specifically, the research is quite limited, but the studies that have been done show that up to 80% of women with kidney failure experience sexual dysfunction. One of the challenges with doing research in this area is that the tool that's most commonly used to assess sexual dysfunction is called the FSFI, which stands for Female Sexual Dysfunction Index. And this tool doesn't differentiate between sexual dysfunction and sexual inactivity. So women who are sexually inactive will inevitably score positive for having sexual dysfunction, even if sexual dysfunction is not the reason that they're not sexually active. So there was a study that was done recently that looked at women with kidney failure being treated with dialysis and administered a modified version of this FSFI, which did differentiate between sexual dysfunction and inactivity. And their results showed that even though many women are sexually inactive, actually very few report sexual dysfunction, and most say that they're satisfied overall with their sex life. But looking at the demographics of this study, the majority of women who participated were post-menopausal. So it really didn't capture the sexual function and activity of young females with kidney failure. So the aim of my project was to look at young females with kidney failure being treated with dialysis and assess the incidence of sexual activity, sexual function, as well as the satisfaction of these individuals with their sex life overall. So we recruited females less than 51 years old with kidney failure from dialysis clinics in Calgary. And we administered the modified version of the FSFI that was used in the previous study. And we also collected some demographic information from them. And then we looked at the results with descriptive statistics. And this first table here is just showing the demographics of participants. So we had 27 participants in total. 22 of them were being treated with hemodialysis and the other 5 were being treated with peritoneal dialysis. The median age of the people that participated was 36 years old and median time on dialysis was 3 years. The next 4 figures are just showing our preliminary results. So among these participants, nearly half were sexually active, so 46%. And then figure 2 is just looking at the reasons for sexual inactivity and those who were not sexually active. And we found that the most common reason was a lack of partner, but actually 25% of participants said that the reason they were sexually inactive was because of sexual difficulty. Figure 3 on the left here is showing the incidence of sexual dysfunction among females who were sexually active. And we found that 92% met criteria for sexual dysfunction based on their FSFI score. And then the last figure here on the right is showing the breakdown in terms of satisfaction with these individuals' sex life overall. And we found that overall, only 13% of individuals said that they were satisfied with their sex life, and actually over 60% said that they were moderately to severely dissatisfied. So overall, our preliminary results show that unlike older females with kidney failure being treated with dialysis, young females are sexually active, and many have sexual dysfunction as well as dissatisfaction. And so this really highlights a major unmet research need, because right now we don't have a great way to identify these women in clinical practice, and we don't have great management guidelines. And it also highlights a need for further research into the etiologies that contribute to sexual dysfunction as well as dissatisfaction in this population. So thank you very much.
Great work. Thank you so much. Yeah, I'll leave the floor open for questions.
I can jump in. I have many questions. I think this is very cool research. Not to scare you, I don't think they're hard. My first question, because I am not familiar with this area, I'd just like to know what is meant by sexual dysfunction. Like what does that look like?
Yeah, for sure. So there's actually one of the challenges with doing research in this area is that there's multiple different definitions. The definition that's most commonly referred to in the research that I've seen is the DSM-5 definition. And it refers to, I'm not going to get the wording correct here, but it refers to generally any inability to perform sexually or experience sexual pleasure. And in order to kind of meet criteria for sexual dysfunction, it needs to be present for at least 6 months and at least, I think, 75% of sexual encounters, and cause distress to the individual. And so broadly, it refers to kind of a number of different symptoms, both physical symptoms. So in females, it can be difficulty with lubrication, or it can be pain during sex or after sex. And it can also refer to difficulties with sexual interest or arousal.
Perfect. Thank you. Yeah, I was just wondering. That's a lot more clear for me. And my other question was, did you look at like demographically sexual orientation and whether dysfunction and dissatisfaction differed between that?
We actually did not look at sexual orientation. We did look at gender, but that's actually a great idea for research going forward.
Awesome. Thank you.
Yeah, no problem. Thanks for the questions.
Great questions. Anyone else? I always have questions. So one thing I was thinking as well, and I'm not sure how the DSM exactly defines this, but I was thinking about how in the reasons listed, no partner was a reason, but someone could technically be sexually active and not be partnered too. So I was wondering if there was plans around like disaggregating that, or how that would be addressed.
Yeah, for sure. So I'm not sure if this will answer your question, but so figure 2 was showing the results only from those who were sexually inactive. So even if the individual had or did not have a partner, but they were sexually active, they weren't included in that figure. So it's only looking at those who were not sexually active. Did that answer your question?
Yeah, something was just tripping me up about that. That was the other this reason where I'm like, okay, that wouldn't account for a physical thing, right?
Right.
Obviously, not necessarily. And I was just wondering if there's, because I'm also not familiar with this area of research at all either, there must be kind of different reasons for postmenopausal versus premenopausal people in terms of the causes of that dysfunction, or are there similarities as well?
No, Yes, I don't know if that has been differentiated in the kidney failure population specifically, but certainly in the general population, the incidence of sexual dysfunction is different, and the reasons contributing to them would be different as well.
Yeah, so the need for they would need different interventions.
Exactly, yes.
Yeah.
Some of the interventions might overlap, but depending on kind of the reason for sexual dysfunction, the treatments would be different.
Yeah, which is why this research is important.
Yeah, exactly.
Great. Any other questions? Catherine? If not, awesome. That was really interesting presentations. I love these presentation series because there's always such a wide variety of topics, but it's all important and there's always a little bit of overlap even in these really different topics. So thank you so much to all the speakers for sharing your work. And I will just say to everyone on the call, if you know people or want to present, we'll probably do one again in September. So, or quarterly. We have a few people interested already in the September one. So if there aren't slots open, yeah, we're trying to do them at least every few months here. So you can send me an email or probably Catherine an email, the network manager. But yeah, just reach out to someone and we'll get you in touch with the right people and give you a chance to share your work. So thank you so much, everyone. And I hope you have a great rest of your afternoon.